Buenos tardes. Welcome to this afternoon session on cardiovascular disease and lupus. My name is Bevra Hahn, and I'm a professor of medicine from UCLA in Los Angeles. The co-chair is Eloisa Bonfa, who's professor of rheumatology from Sao Paulo, Brazil. And our speaker is the famous Professor Susan Manzi, who's a professor of medicine at Pittsburgh. Dr. Manzi.
Thank you, Dr. Hahn, Dr. Bonfa, and to the organizers for letting me be a part of this wonderful international meeting. It's really a privilege. So my charge this afternoon was to talk about cardiovascular risk assessment, but to keep it practical and to try and focus on practical approaches to management. So I will try to do that. So what I'd like to start with is pointing out why lupus, and this is actually a huge breakthrough for us in the United States, but lupus has finally gotten the attention of the American Heart Association. And to put that in perspective, the American Heart Association is the American College of Rheumatology equivalent in the United States. And for the first time, and I'll show you on guidelines that were just published, that they recognize lupus as an independent risk factor for cardiovascular disease. So that's a huge accomplishment for us. I'm going to review for you and try to keep this evidence-based the data that we have on management of cardiovascular disease risk in lupus, and I'm going to focus, even though few, on some of the randomized controlled trials. And then I'm going to end with guidelines that you can take with you for primary and secondary prevention for cardiovascular disease, using lupus as an at-risk population for women as have been determined by the American Heart Association. I will say that the position paper that I'm going to refer to in this comments about international applicability. So all of these guidelines are translatable to international populations as well. So let's talk a little bit about why lupus has gotten the attention of the American Heart Association, which truly is a breakthrough. I show you this picture because this was a slide taken from when I was a medical student, and we were learning about heart disease in the 1980s. And in the 1980s, heart disease was defined as you can see here, it was a man, somewhat overweight, just leaving a restaurant, probably having eaten a fat-laden meal. He has his briefcase there because he's probably type A and overworked, comes out into the cold weather and clutches his chest. That was heart disease, and that's how we learned about heart disease. But women have come a long way, and probably not in a good way, but it's taken time for the recognition that women also have this as a major concern. And I got a kick out of looking back over the past almost half of a century, really, at how this has evolved. And again, this is from the US, and again, the American Heart Association. So in 1960, if you went to the American Heart Association and you were a female cardiologist, which wasn't common, the only session that you could attend in 1960 was one that was called, "How Can I Help My Husband Cope with Heart Disease?" And I mean, 1960, you know, I was born before then, so it's a little frightening to think that that's where we were. About 12 years later, the American Heart Association put out a pamphlet on healthy eating entitled "The Way to a Man's Heart." It wasn't until 2002, which is extraordinary, that the AHA initiated for the first time a program for women to highlight heart disease. And they called it the Heart Truth. And then in 2004, for those of you in the US who are very familiar with this, the Go Red Women campaign came to be, which increased awareness of heart disease in women. And so there are statistics about in the general population that more women than men die from heart disease, at least in the US. And this is just showing you some of those figures. You can see that around 1985, women surpassed in the pink men in terms of CV disease mortality trends. They continue to die more frequently than men of heart disease, even though the general trends are going down. 1 in every 3 women, at least in the United States, have some form of heart disease, and only 10% of U.S. women are considered optimal risk. That means have no risk factors whatsoever for heart disease. But we know that lupus is different, and even though women are commonly have issues with heart disease in the non-lupus world, lupus women present a significant challenge. They're young, they've got a lot of other comorbidities and issues, and we have, I think, a unique dilemma in front of us, or complexity and challenge to deal with. This particular patient was a patient of mine who died at the age of 27 of a coronary heart event. But this is where I think we have to take some, as a sign of hope moving forward. These are the recent American Heart Association guidelines that are for prevention of cardiovascular disease in women, and they were updated in 2011. The last time these were put out was in 2007, and I'm going to show you some very important distinctions. This expert panel committee came together and, using very stringent evidence-based studies, randomized trials, put together guidelines and recommendations for primary and secondary prevention of heart disease in women. This is the article where I'll show you that they comment specifically about lupus. When this position paper came out, they got the endorsement and imprimatur from almost all of the other colleges in the United States, including the American College of Obstetrics and Nephrology and the American College of Physicians, and they also passed it on to their international colleagues for endorsement as well. So I would encourage you to read this document. In this document is a Table 2, and it's probably hard for you to read out there, but I'll point out a few things. They classified women based on their CVD risk, and they classified them in 3 ways. What they considered very high risk, at risk, and what I cut off at the bottom was minimal or optimal risk, those women that had very minimal, if any, risk factors. What is exciting about this is that for the first time, if you looked at this table in 2007, you would not have seen this, but in 2011, they actually commented that systemic autoimmune collagen vascular disease, lupus, and rheumatoid arthritis made it into the category of at risk. It is not in the high risk category, which is prevalent coronary heart disease, end-stage chronic kidney disease, diabetes, or a 10-year predicted CVD risk of greater than 10%. That used to be greater than 20%. They reduced it to 10%. But it did make the list independently as a risk in the setting of hypercholesterolemia, hypertension, obesity, family history, cigarette smoking. So this is truly important for us, and it's new since 2007. In the text of the article, they say more about lupus and RA, that it may be unrecognized risk factor for women and has been associated with a significantly increased relative risk of cardiovascular disease. They go on to say that women with such conditions, but without clinically evident CVD, should be considered at risk and screened for CVD risk factors. And this is really the first national publication to make a statement like this. They go on to say something that I think is even more interesting. They go as far to say that women with a prior CVD event who don't have lupus should be screened for these conditions, lupus and RA, to allow for appropriate secondary prevention and to allow for the autoimmune condition to be addressed. So they're actually recommending that if a woman comes in with a new cardiovascular event, you should consider that there may be an underlying autoimmune disease. I think 2 very significant statements. So in lupus, there's many reasons why I think we've gotten their attention. I'm not going to spend my time discussing those, but to just give you a brief overview, we all know a lot of these data. Obviously, we have shown that myocardial infarction rates are significantly higher in women with lupus compared to women without lupus in the red bars, and you can see that these incidents of myocardial infarction are increased in every age group from 15 to 74. We've also shown that there is about a fold to fourfold increased risk of being hospitalized with either an MI, congestive heart failure, or stroke if you have lupus and you're between the ages of 18 and 44 than if you don't have lupus. And this work was done by Michael Ward when he was at Stanford. In the Swedish literature, they've shown something similar, that you have about a 2 to 3-fold increased risk of being hospitalized with coronary heart disease or stroke if you have lupus compared to not lupus, and in fact, a 16-fold increased risk if you are of the ages of 20 to 39. And when you look at incident coronary heart disease in lupus compared to diabetes, you can see that about 13% of lupus patients will have some coronary event in a 12-year follow-up versus 20% of diabetic patients in 7 years. Now, if you look at the article that I just showed you, what's considered very high risk are women that have a 10-year cardiovascular disease risk of greater than 10%. So you can see that lupus patients aren't quite there in terms of the strict definition, but if you consider the mean age of the lupus patients compared to the diabetics in these studies, and the fact that the majority were female, it does make you pause and wonder whether in the next update of these criteria, whether lupus may actually be moved to the high-risk category. We know that the disease that our patients get is primarily atherosclerotic in nature. And we also know that they have worse outcomes once they have coronary events. So if you look at 1 year after a lupus patient has a percutaneous coronary intervention like an angioplasty, what you'll see is worse outcomes in this bar of lupus patients in 1 year after a percutaneous coronary intervention versus non-lupus patients here in terms of requiring a repeat intervention, having a myocardial infarction, or having any major coronary heart disease event, which is death, MI, revascularization, or another intervention. We've also shown that compared to diabetics post-MI, that lupus patients have higher rates of prolonged hospitalization, and their trend is toward increased in-hospital mortality. And plenty of institutions have shown that they also have increased subclinical cardiovascular disease as measured by carotid plaque and coronary calcification. And I will comment that in that risk chart that I showed you in the circulation paper, having subclinical cardiovascular disease is considered an independent risk factor as well. Does having subclinical carotid plaque mean anything? Does that have any impact on your risk of having an event in the future? The answer to that is probably yes. When we looked at time to occurrence of a cardiovascular event stratified by whether you had carotid plaque in the red bar here versus not having carotid plaque, what we found is that you had a 5-fold increased risk of having either an MI, stroke, percutaneous coronary angioplasty, or revascularization at 10 years if you had carotid plaque, which means that that may be a risk stratification tool for us. I'm not going to spend time on this because I want to get to treatment recommendations, but I will say that many people in this audience and many people at this International Congress have put a lot of work into trying to risk stratify patients with lupus and identify who are those patients at our highest risk. People have proposed panels of biomarkers or risk equations that we might use to, within the high-risk lupus group, that they've already been deemed high risk, we can actually identify those at most risk within the high-risk category. And we have, many people have proposed looking at inflammatory markers or pro-inflammatory HDL, circulating endothelial cells, homocysteine, oxidative stress, complement activation, phospholipid antibodies, and a plethora of other potential immunologic markers that may help us stratify. But what I'd like to spend some time on now is reviewing the evidence that we have currently, which is not much, but I'll show you what it is, on management of cardiovascular risk in lupus from randomized controlled trials. So one of the questions we ask are statins effective in reducing cardiovascular risk in lupus? I'm going to show you the results of 4 randomized placebo-controlled adult trials. I will not talk about the adolescent trial, and I'll let you make your own conclusions, and I'll tell you how I've interpreted these data. The first is Dr. Petrie, who did a randomized trial of atorvastatin versus placebo. It was the LAPS trial. She randomized 200 lupus patients, 92% were female, mean age of 44, and randomized them to atorvastatin 40 milligrams versus placebo and followed them for 2 years. The primary outcome in this study was change in coronary artery calcium score. But secondary outcomes included changes in disease activity, biomarkers, and carotid disease. Although it may be hard for you to read the results here, these are p-values that are not significant. Basically, at the end of the trial, there was no benefit on changes in coronary artery calcification, changes in carotid IMT, or plaque in the atorvastatin versus placebo group. However, in a post hoc analysis in the paper, what she looked at were the proportion of patients on atorvastatin that had no change in the intima media thickness over the 2-year period versus those that had worsening of IMT compared to placebo. And what you see is that there was a statistically higher number of patients on placebo who had worsening of their IMT, even though the change variable, which was the outcome of choice in the study, was not significant. There was no benefit seen in disease activity, which was measured cumulatively over time. There was a reduction in total cholesterol, but there was no reduction in high-sensitivity CRP or other biomarkers. And one warning that she made in the paper was that they noted LFT elevations in about 51% of the atorvastatin group versus 30% of the placebo, and those could be seen even as far as 18 months into the trial, but no CPK elevations. The second study, done by Placebo et al., and this was out of Poland, was a randomized trial of atorvastatin again. 60 patients were randomized. It was a 1-year trial, and it was 40 milligrams of atorvastatin versus placebo. Their primary outcome was also coronary calcification, but they used a multi-detector CT methodology, and they also looked at myocardial perfusion changes using SPECT scanning. Their secondary outcomes also looked at changes in CRP over the year's trial, lipid levels, and changes in the SLEDAI, which were basically baseline to end visit. In this study, they had different results as opposed to the last study. As you can see here, in the people that were randomized to placebo, they had significantly increased plaque volume in the coronary arteries and a significantly higher calcium score than those that were on the atorvastatin. They also showed in the patients on atorvastatin significant reductions in high sensitivity CRP, triglycerides, LDL, and total cholesterol versus those on placebo. They showed no changes in disease activity and no changes in myocardial perfusion, and they did note that the drug was well tolerated. The third randomized trial was rosuvastatin, and for those of you that know trade names, this is Crestor. This study was done by Mok et al. In Hong Kong. It was a study of 72 patients. You can see they were slightly older, 50 years of age, but mostly women. They had no disease activity or low disease activity, but they were brought into the study based on the fact that they had subclinical cardiovascular disease detected either by coronary calcium score or by a thickened intima-medial thickness. They were randomized to 10 milligrams of rosuvastatin, and what they did in this study is in both arms of the placebo and the rosuvastatin, Half in each arm also got 80 milligrams of aspirin, and that was because they had planned to do a longer-term extension looking at thrombotic events, but that part of the study did not happen in the end, but they still had information on the added effects or benefits of aspirin. Their outcomes in this study were primarily one-year biomarker outcomes. They looked at changes in homocysteine, high-sensitivity CRP, adhesion molecules, and thrombomodulin, and their 2-year outcome was looking at changes in progression of carotid IMT over 2 years. The results of this study, they did show at 1 year significant decrease in high-sensitivity CRP, total cholesterol, and LDL with the rosuvastatin group, and they did control for things like disease activity, medications, age, and sex. They showed no difference, however, in IMT. I don't show you the data here, but like in most of the studies, there were trends toward less IMT progression in the rosuvastatin versus the placebo group, but they did not reach statistical significance. They showed no added benefit with aspirin, and there were no adverse effects. The drug was very well tolerated. And the final trial I think is interesting. This trial was this is a group from Norway and Canada and Sweden, and what they did was a sub-analysis of a large fluvastatin trial, which is Lescal, versus placebo in lupus renal transplant. The original trial, the ALERT trial, looked at 2,000 renal transplant patients, not just lupus. What they did was pulled out 33 of the patients within the larger parent trial who had a renal transplant because of lupus. The mean age of those patients was 47 years, and those patients were randomized to either fluvastatin 40 to 80 milligrams for 5 to 6 years, and then they were rolled over into a 2-year open label study where they got drug. The outcome in this study was a very hard outcome. This was time to event at a mean of 7 years later. They looked at MI, cardiac death, and coronary intervention. And they showed a very striking protective effect of fluvastatin with a 73% risk reduction in those on the drug versus not on the drug for time to first cardiac event. They also showed a lowering of LDL cholesterol and of total cholesterol. So if we summarize the statin trials in lupus, we can say, I think, pretty clearly that these drugs are well tolerated. You need to be careful of LFT elevations, and these are the 3 statins that were reviewed. They all appear to effectively reduce total cholesterol and LDL, and they effectively reduced high-sensitivity CRP in 2 of the 3 trials that measured it. None of the trials showed an impact on disease activity, although it was measured in a variety of different ways in the trials. But I would argue that there were clearly trends and/or significant reductions in coronary calcium and carotid IMT progression and cardiac events in renal transplant. And whether they reached statistical significance or not, I think the signals were clearly there in some of the studies and clearly met significance in others. Another question that we frequently ask, and I think our RA colleagues have done a much better job at looking at this, is whether our disease-modifying agents, if you will, or immunosuppressive agents are effective as well in reducing cardiovascular risk in lupus. And I can tell you that there are barely none. I don't think any randomized trials that have looked at this question, but I will show you some interesting animal data and some observational data. And I'm going to look at mycophenolate mofetil, which actually has the most information. There was an interesting study just published in 2013 of a murine model of lupus, which is a model of lupus and accelerated cardiovascular disease. In this study, they had 7-week-old mice that they randomized to, they were all on high cholesterol diets, and half of the mice were with and half were without mycophenolate mofetil, along with the high cholesterol diet. What they showed is after 12 weeks, those on mycophenolate had less plaque progression and improvement in their nephritis and autoantibody status. And this is just a diagram of showing you using an oil red O stain. These were the untreated mice. These are the aortas showing the staining of atherosclerotic plaque versus those on MMF. And if you quantitate the plaque, you can see that the MMF group clearly had significantly less plaque, and they had a slight, if not a significant, reduction in their total cholesterol as well. So the authors in this study really speculated that whether it was effective treatment of the underlying disease, which they did see, in terms of reduction of nephritis and autoantibodies that led to the improvement in atherosclerosis, or whether it's something specifically about MMF was really unclear. Another study, and this was, I think, more of an observational study within the Atorvastatin randomized trial, Dr. Petrie's group published recently, looking at whether or not mycophenolate had any impact on reduction of subclinical atherosclerosis using these measures that we talked about before in the Atorvastatin randomized trial of carotid IMT and coronary artery calcification at 2 years. So within the patients that were randomized to the Atorvastatin trial, 25 of them were on mycophenolate mofetil. And the duration of use of the drug throughout that trial was anywhere from 84 days to 2 years. And they looked at whether there had any impact in patients on MMF on reduction in subclinical atherosclerosis. And what they found was no association between the use of MMF, whether people were on low dose, high dose, or any dose, with reduction in cardiovascular disease prognosis. Small numbers, really an analysis within a much larger randomized trial, but at least some interesting observational data to the contrary of what I showed you with the animal studies. So with MMF, there are murine models. There was other murine models that I didn't show you. I just showed you the one from 2013 that do suggest that MMF can reduce disease activity and plaque progression. But there are no randomized trials of this drug in cardiovascular disease risk reduction in human lupus. Now, what about hydroxychloroquine? Is it effective in reducing CVD risk in lupus? I think we've all come to love hydroxychloroquine. We know its mechanism of action is blocking toll-like receptors and inhibiting interferon alpha and TNF alpha. And we do appreciate that hydroxychloroquine has benefits beyond disease activity. Groups have shown that it improves lipid profiles after only 3 months of treatment, both total cholesterol and LDL. It reduces the risk of diabetes and rheumatoid arthritis. This was a nice study published in JAMA by Dr. Mary Chester Wasco, who showed that the probability of developing diabetes and rheumatoid arthritis was impacted by use of hydroxychloroquine. In those that never used hydroxychloroquine, they had the highest risk of incident diabetes versus those who ever used it versus those who used it for more than 4 years. Hydroxychloroquine has also been associated with a greater reduction in hemoglobin A1C in diabetic patients with rheumatic diseases, published by Dan Solomon's group in Boston. And the Lumina cohort, Chela Alarcon has done such a great job with a multi-ethnic longitudinal cohort in clarifying the natural history of lupus. And she certainly has shown that hydroxychloroquine reduces damage accrual, is associated with improved survival, a decrease in flares, a decrease in renal damage, and a decrease in skin damage. This beautiful study done by the Gladle cohort, the Latin American cohort, and our hosts here for the meeting, another beautiful Inception cohort of 1,480 SLE patients, 77% of them on anti-malarial users. What they showed here was a substantial reduction in mortality in the users of Plaquenil based on the length of use. So you can see mortality figures here in non-users, defined as anything less than 6 months of hydroxychloroquine use. You can see no significant improvement if you're on up to a year of hydroxychloroquine, some improvement potentially over a year, but significant reduction in mortality with greater than 24 months use of hydroxychloroquine. And mortality differences in the users and non-users was 4.4% versus 11.5% in the cohort. What about anti-malarials in reducing vascular events? This was a nice case control study, a nested case control study by Dr. Paul Fortan, where he pulled out 54 cases in his lupus cohort that had thrombotic events. 32 were arterial, 22 were venous. He then matched 102 controls to those cases, all lupus patients, that were matched by first-year visit, duration of follow-up, and disease activity. And what he showed was that every use of anti-malarials was protective against vascular events, with a 70% reduction in vascular events in those on Plaquenil. Now, I mention this because in the spirit of speaking about heart and heart health, I think it's important to point out that we cannot forget that there is an anti-malarial cardiomyopathy. Fortunately, it's rare, but just recently published in Lupus and in the European Heart Journal, it brings to our attention again that this is a real toxicity of Plaquenil, usually after long duration of use, and to remember that it's weight-based dosing. This is just an example of the typical findings on a muscle biopsy, either peripheral or endomyocardial, which shows the classic curvilinear bodies and vacuolar changes, and can present as somebody presenting with biventricular heart failure. So keep in mind that this can be diagnosed by an endomyocardial biopsy. Fortunately, in the studies presented in the most recent literature, it was reversible in most cases on stopping the medication. So the summary of hydroxychloroquine in CVD: hydroxychloroquine has many potential benefits beyond disease activity, including glycemic control, lipid profiles, mortality, damage, and vascular event reduction. But beware of the rare risk of the drug-related cardiomyopathy. Are antioxidants effective in reducing cardiovascular disease? We would like to think that they are. I think the data here from TAM, again out of Hong Kong, was a randomized placebo-controlled trial of vitamin C and vitamin E in 39 women, mean age, and it was a 12-week trial. You can see they were randomized to 500 milligrams of vitamin C or 800 international units of vitamin E versus placebo. Their primary outcome was a measure of lipid peroxidation. Malondialdehyde, or MDA, is a serum marker of a byproduct of lipid peroxidation, and so high levels suggest oxidative stress and more peroxidation or lipid peroxidation, which is a bad thing. And they also looked at endothelial function using brachial artery flow-mediated dilation, and they looked at von Willebrand and Pi1. They found that the vitamin C and vitamin E were well tolerated. They saw a very modest and insignificant reduction in serum levels of MDA, or lipid peroxidation surrogate. And they found no impact on other oxidative stress or endothelial function. And I would add that that's probably no surprise considering what we know about vitamin C and vitamin E in the non-lupus population. And I point your attention to a great review article published in 2011, which was a meta-analysis of large randomized trials looking at cardiovascular death in trials on people randomized to vitamin E and beta-carotene. These were non-lupus patients, 200,000 patients represented in these trials. Now, if you look at this visually, I can walk you through it. Up here are the trials representing vitamin E and vitamin C, and here are the trials representing beta-carotene. Anything on this side represents vitamin E being worse for cardiovascular death, and on this side, better in terms of reduction in cardiovascular death. And you can see here is the same: beta-carotene worse, beta-carotene better. And I think you can look at this and see that there probably was no benefit in vitamin E and a concern signal with beta-carotene. And in fact, these were the trials 80,000 patients in vitamin E, 130,000 with beta-carotene. They showed no effect with vitamin E, but a mild increased risk of mortality with beta-carotene. So the current recommendations that I'll show you at the end is really to not use vitamin E or beta-carotene as a primary prevention or secondary prevention for cardiovascular disease. What about omega-3 fatty acids? I did find one randomized trial in lupus. This trial was done, I believe, in Ireland. This was 60 patients, again, mostly female. They were randomized to 3 grams of omega-3 fatty acids versus placebo, and they were followed for 6 months. Their outcomes here were disease activity measured by SLAM and BILAG. They looked at endothelial function, and they also looked at another great marker of oxidative stress, this platelet 8 isoprostane, which is thought to be probably an even better serum marker of oxidative stress. They did, however, show with omega-3s significant reductions in disease activity, improvements that were pretty dramatic in flow-mediated dilation, and significant reduction in oxidative stress at 6 months. And again, this probably isn't surprising since there are an equally large number of studies in non-lupus showing benefits of the omega-3 fatty acids. So summary, no role for vitamin C or vitamin E, and maybe potential beneficial role for omega-3 fatty acids. So let's get to the final guidelines and what we might recommend moving forward for our patients with lupus. And what I'm going to show you are guidelines published by the American Heart Association that are felt to have international applicability and include for us, for the first time, lupus as an at-risk population of women that could follow these guidelines. What I'm going to show you here in the next few slides are the data presented as either being Class 1 data, Class 2 evidence, or Class 3 evidence. Class 3 evidence means that it's strong evidence against the use of these interventions because there is either no impact or a detrimental impact. Class 2 is that there is a general favoritism toward these interventions, but not based on a large number of randomized trials. And Class 1 is fairly rigorous randomized trials with plenty of data to support the use of these interventions. So I'm going to show you first what doesn't work, and these are the Class 3 interventions. One is hormone therapy and selective estrogen receptor modulators. What this is saying is that these agents, although they may be safe in lupus patients or in patients at risk for cardiovascular disease, they should not be used specifically for primary or secondary prevention of cardiovascular disease. Antioxidants, as we just discussed, should not be used for primary or secondary prevention. Folic acid with or without B6, B12 supplementation should not be used for primary or secondary prevention because there is no evidence to support it. There is no negative evidence, but there's no evidence to support it. They do make a stipulation, however, or an exception that pregnant women should be on folic acid because of neural tube defects. Interestingly, the world has changed in terms of the recommendations for aspirin use in women less than 65 years of age. It used to be a part of the primary recommendation in the 2007 guidelines. It is no longer in the recommendations because it is felt to be good for primary prevention of stroke, but not for coronary heart disease. Now, again, this is in women at risk, less than 65 years of age. There are some exceptions to that. And again, they don't specifically pull out women with hypercoagulability, antiphospholipid, etc. But I think it is important as a primary prevention in otherwise uncomplicated lupus patients, it is not being recommended. I bring us back to the table I started with where we showed lupus here in the at-risk group, just to point out that these other at-risk categories, including metabolic syndrome, which about 25% of lupus patients have, and these other risk factors are important for us to consider as well. Why is that? because data nicely presented by Murray Urowitz earlier this week, where he looked at the SLIC cohort, which is about 1,400 inception patients from 30 centers across the country, multi-ethnic patients, followed them a mean of 5 years, and looked at those patients who did not have an atherosclerotic vascular event versus those patients who had an atherosclerotic vascular event from time of entrance into the inception cohort. And what you can see here is that common traditional risk factors are present in patients with lupus who have events, more so than those that do not have events. Obviously, male sex was more common in the event patients. They were obviously older age, but there was a trend toward more diabetes, higher Framingham risk score, smoking status, obesity, hypertension, a trend toward hypercholesterolemia, and renal disease. The point here is that these are real risk factors and modifiable risk factors that are seen more commonly within lupus as an already high-risk group as being other indicators of an even higher risk to the lupus itself. When he did a time-to-event analysis of this same cohort, again you can see that age, male sex here is less relevant for us with, since I'm focusing on women, but Framingham risk score, smoking status, obesity, hypertension, and hypercholesterolemia again become important predictors of time to event. So in terms of Class 1 recommendations, these are the ones with the most evidence and that are important for us to consider as useful and effective, and they are important for everyone in that at-risk category. Interestingly, a real push toward lifestyle interventions, way more than pharmacologic therapies in the new guidelines. Smoking cessation, way up at the top. Dietary interventions, and important information, I think, for us and our patients. Regular physical activity, but it doesn't have to be oppressive. In the guidelines, they say that 3.5 to 4 hours a week of moderate to vigorous exercise is sufficient, keeping in mind that this exercise could be done in 10-minute increments and still be effective. So for our patients, that may be relevant. And muscle strengthening has just as an important impact on cardiovascular health. And if you can do any kind of low weight training or muscle training 2 days a week, that has a major impact. And obviously weight management. So you can see 4 of the top Class 1 recommendations for interventions are lifestyle interventions and things that clearly have been identified in many cohorts as being more common in our patients who have events than those that do not. In terms of blood pressure control, I think this is, again, a little different than what we've been promoting in the past. What they say is that you should try to use lifestyle interventions to keep blood pressure less than 120/80, and only think of pharmacologic therapy if blood pressure is greater than 140/90 or 130/80 if you have kidney disease or diabetes. So they are basically raising the bar a bit of moving in with pharmacologic interventions when you should try to use lifestyle reduction first and maybe increasing the bar unless you have kidney disease or diabetes, which may be relevant for our patients. And interestingly, for LDL cholesterol lowering, for a while we were promoting pushing way low on the LDL cholesterol. And what they're recommending, and I tried to do the conversion here from the US to the European and Canadian levels, is that only do you treat LDL cholesterols greater than 100 if you are in that high-risk group. So the diabetics, the coronary heart disease, and the chronic kidney disease. But probably don't need pharmacologic therapy unless you're over 130 or 3.3 in the at-risk group, which included the lupus group. Now again, there's other reasons why we may want to push, but I think this raises the bar a bit of when we need to intervene with statins or other LDL-lowering therapies. And again, aspirin here is reserved for older patients, coronary heart disease equivalent patients, and atrial fibrillation, and only if there's another reason to use aspirin because of hypercoagulability should it be considered. They did recommend as a class 2 recommendation, again, this is without a lot of randomized trials, but with enough evidence to favor the use are the omega-3 fatty acids at 1,800 milligrams a day, particularly in our patients with high total cholesterol and triglycerides. The class 2 recommendations, which means that there is not a lot of data to support this, is pushing LDL below 1.8 or 70, and they suggest it only be reserved for women that have had a recent acute coronary syndrome or have really refractory other risk factors for hyperlipidemia. And they also are not strongly recommending HDL raising therapies such as niacin or fibrates. They can be considered, but they are not class 1 recommendations. And finally, this idea of strict glycemic control, as I think we all know, those rules and regulations are loosening a bit as well. And there is some class 2 recommendation for hemoglobin A1Cs less than 7, but again, it's only class 2. So in summary, lupus has gotten a tremendous amount of attention, at least from the American Heart Association, finally, just in the past 2 years, as a unique and independent risk factor for cardiovascular disease. They suggest screening of women with lupus for cardiovascular disease risk factors and screening of women who come in with cardiovascular events for lupus, which is extraordinary. There is a paucity of randomized controlled trials for primary or secondary prevention in lupus. But in the trials that we have, statins were well tolerated. They were effectively reduced lipid levels. They seem to have no effect on disease activity, and they may favorably impact biomarkers, and there are clearly signals of potential benefit in cardiovascular disease risk reduction, particularly using surrogate markers of subclinical disease, and hard outcomes, at least in renal transplant. There are interesting animal studies that support the use, very much like the rheumatoid patients, that if you get disease under control with the TNF inhibitors or methotrexate, you'll see less cardiovascular disease, that potentially MMF may have that impact in reducing cardiovascular disease. We do not have significant human data. Hydroxychloroquine may play a role in cardiovascular disease risk reduction, glycemic control, damage, vascular events, and mortality. I caution you about cardiomyopathy. And there may be a role for the omega-3 fatty acids in endothelial function and oxidative stress reduction. There is no role for hormonal therapy as primary prevention, vitamin E, vitamin C, beta-carotene, folic acid, B6, B12, or routine use of aspirin for coronary risk reduction. It is good for stroke risk reduction. And if we extrapolate from the AHA Class 1, Class 2 guidelines for at-risk women, these may prove to be useful in the management and prevention of CVD in lupus. And I would remind you again of some of the deviations in terms of use of aspirin, where we may start pharmacologic therapies with LDL, blood pressure control, which may be loosened a bit, the use of omega-3s, and a strong push with lifestyle modification. So the paradigm has shifted from when I was in medical school, thank God, that cardiologists were all about pumps and clogged pipes. And now cardiovascular disease is really a disease of rheumatologists and immunologists who are interested in macrophages, cytokines, T cells, and inflammation. And we are now venturing into treatment strategies that look at lifestyle modification, glycemic control, omega-3s, biologics, antihypertensives, and lipid-lowering agents. So I will end there and open the floor for questions.
Thank you. Are you coming to the microphone there in the center?
Is there anyone there?
Don Thomas from Maryland, United States. Thank you for a very, very nice talk. I think you met your goal with giving a practical lecture as a clinician. I thank you very much for that. My question goes to Dr. Hahn. I find your data on pro-inflammatory HDL to be quite fascinating. And now when I get lipid profiles on my lupus patients, in the past, if they had a high HDL, I would say, hey, this is going to protect you from heart disease. But now with the pro-inflammatory HDL, it makes me really question that. I'm just wondering if there's anyone looking at getting pro-inflammatory HDL levels from a clinical, practical use in the clinic.
Well, I'll tell you what I think, and Dr. Manzi can correct it. I think the problem with the pro-inflammatory HDL world is that they're very difficult to measure with a lot of variability in assays. And there's a big push to develop an Eloisa type assay that can be used universally to measure these. Until that happens, it's going to be pretty difficult to do any kind of manipulation that can be widely used in practice. So that is a drawback. There is plenty of evidence that they're important, and pro-inflammatory HDL cannot prevent oxidation of LDL like normal HDL do. So when you measure total HDL, it doesn't tell you what the function of the HDL is. Anything that promotes oxidative damage and oxidation tends to produce pro-inflammatory HDL. So I think they aren't ready for use yet. There is some work in labs that can measure them on many of the things that Dr. Manzi's already covered to ask if they influence PI HDL, and I think we're not ready yet to be sure about that. Dr. Manzi, please correct.
First of all, I'm a big proponent of the idea of going beyond what I've showed you as pretty practical interventions, because there's a lot more. I think there's a lot more to lupus than what I've shown you. I tried to keep it practical. I totally agree that I think the future will be making these assays accessible, making them easy to measure and commercially available, and coming up with exactly what was presented earlier in the meetings, a panel of biomarkers that may then, within the lupus group, identify the highest risk patients as well. That may be imaging on top of pro-inflammatory HDL, on top of some of the other factors that some of the speakers had mentioned, Dr. Petrie and Dr. Hahn's group. So I think that's the future.
We have one more question there, the last one.
Sarfraz Hasni from Bethesda, Maryland. So I'm having problem with your extrapolating the AHA guidelines to the patients with lupus, because patients with lupus seems like that their cardiovascular disease pathogenesis and evolution is somewhat different than non-lupus patients getting cardiovascular disease. And as you see, the multiple studies showing that lipid-lowering therapies in patients with lupus are not as effective. So based on those studies, how do you extrapolate the AHA guidelines to lupus patients?
So I guess I might differ with the idea that, for example, statins don't work in lupus patients, because I think the data that I showed you, there are clearly trends toward benefits of statins in lupus, benefits of omega-3 fatty acids in lupus. And keep in mind that the trials that we have at all in lupus right now are very small and very few randomized placebo-controlled trials. So I think the answer is we don't know whether or not they would or would not respond. What strikes me, though, is I don't think we should think that lupus patients, that we don't have to be aggressive on traditional risk factor modification in lupus. There's no reason to think that we shouldn't be aggressive with traditional risk factor modification. And in fact, I think I showed you some data suggest it will help, just like it does in other high-risk populations. It may not be everything, but I do think it will be helpful.
Okay. Thank you so much.
Thanks.